So thank you, Corey, for having me back. I think this is the third, maybe fourth year I've done this topic, so it must be a popular topic. And Corey said over dinner last night, yeah, you must have a hard time finding literature on that. I said, actually not. So there's actually quite a bit of literature that keeps coming out each year on this topic. So we're going to talk about a little bit about this why hope versus reality collide. Some end-of-life care and goals and difficult discussions, though Pallavi Kumar is going to talk about family meetings, so I don't want to overlap too much with her program. So again, two main strategies about how we're going to talk to our patients in these situations. I'm going to show you some data looking at both patient studies as well as provider studies and what we've said about it. And then number two, it's an art. It's an art no matter how you look at it. This is something that requires you to have a relationship with your patient and their family and be able to talk to them about one of the most intimate moments of their life, about death and dying. Now, before I go on to the next slide, I added these two slides this year because I thought, okay, the obvious. Hope and reality collide because people want to live. Despite what we may think, people actually like their lives here on Earth and they want to live. Number one. Number two, most of them aren't medical professionals. So when they're diagnosed with cancer or lung cancer, they're not really aware of the fact that how bad this disease may be and how soon their death may be coming. So this is why hope and reality do actually collide. But I think in the past year or two, it's actually gotten even a little bit harder for us because of this. So we're now dealing with direct-to-consumer advertising. And I put these three things up there. We talked about this over dinner last night. So the fact that, okay, let's say Wheaties makes you think you're going to play basketball like Michael Jordan if you eat Wheaties. I sort of thought that when I was a kid, honestly. Now, Corey came up with this middle one last night, which might be before my time, but this was Wonder White bread, and he distinctly remembered that Wonder White bread was supposed to make you a bodybuilder in 12 different ways. I'm pretty sure that bodybuilders nowadays wouldn't say that eating refined carbohydrates is adding lean muscle mass to their body. But back then, and then my favorite one is that more doctors smoke Camel cigarettes than any other cigarette, maybe leading us to believe that there must be some kind of health benefit there because more doctors choose that one. So I think clearly none of these is panning out nowadays, that eating Wheaties is going to make you play great basketball and certainly not become a bodybuilder with refined carbohydrates, and we know the cigarette story. But I think, we have dealt with now television commercials, certainly a slogan, a chance to live longer. Now that comes into our clinic. Magazine ads that are not just in the JCO, they are now in Family Circle and your Reader's Digest, so they're out there for everyone. Radio commercials are being peppered all through about cancer and cancer centers, certainly handouts. And then it's not only that, it's our own cancer centers. So I went, this is just a Google search of some of the top 20 cancer centers in this country, and these are the slogans that are associated with the advertising of the top 20. You know who you are out there. So there's not going to be a match the cancer center to the slogan here, but the cure is within. Making cancer history, cancer nice try. When cancer invades your life, you want a miracle? Come on, this is pressure here. The goal seems insurmountable. We achieved it. This is on an advertising internet campaign. You need more than a second opinion. You need a second chance. How can we compete with that? And that's what we're dealing with, though, now. So I think more than ever, hope and reality are actually colliding, not just due to reality, but also because of some of the marketing campaigns, not just by general marketing, but by our own cancer centers as well. So that being said, let's talk about some of the literature that is out there. And this is a new paper that I was able to come across this year, new novel therapies that we have. So back when I started this, 14 years ago or something, everyone that came through the door got paclitaxel and carboplatin for lung cancer. It's what we had, it's what we did. And it made you sick, but I got nothing else, so this is what we're going to do. Nowadays, we have newer novel therapies. Now, this study, this Fallowfield study, was not just lung cancer, so this was all comers with cancer. It was a study done in the UK, and they were giving a questionnaire to physicians after they saw patients to basically say, what did you tell them their therapeutic gains were from whatever drug combination you were going to give them? And what they found out is that the physicians were actually overestimating the actual data that was published data that was out there for whatever reason. And I can't say I might have not have ever done this in my life either, when you have a patient there like, with their eyes wide and the family members there, and you say, oh, it's maybe a little bit better than, what I thought, So we are maybe a little bit guilty of that sometimes. And It was interesting, too, in this study because they said that not only the physicians often were more optimistic about the treatment actually working, they changed it based on individual patients. So I'm thinking like stage 3 lung cancer, depending on the study you look at, locally advanced, what the 5-year survival rate is, you could go anywhere between like 20, 35% 5-year survival rate. But who do you say 20 to 25 and who do you say 35% to? So we may have all been a little bit guilty of that, and it actually differed from individual patients. The other thing I've run into is these newer drugs, less toxicities. So let's take immunotherapy, for example. I'm going to tell you a patient of mine, he's a judge. He had a MET mutation, so he'd had several therapies, and he was on nivolumab, and he had leptomeningeal disease. So he was declining from his leptomeningeal disease. He had had a lot of therapies, and he was probably at I would say a PS of 2.85. I would go there, probably about a 3. So he comes in for his 3rd nivolumab, and we started talking about, like, should we be continuing this? And the thing is that if this was 4th-line gemcitabine, it's a no-brainer. No, I'm not continuing this. I don't want to flirt with lowering your blood counts and make you feel terrible. But the immunotherapies don't have that many toxicities. So where do we draw the line? And where do we say, is this ethical to continue doing this, when this is probably futile and not working? So that was a really hard decision for both him and me to just help him make. Ultimately, he decided to stop therapy because he knew that he was declining. And it was unlikely that probably the drug was helping him. But I think it was a lot easier when we had the good old chemotherapy that just made people sick. So it was easy for me to say, well, no, I don't want to make you sick, so let's not continue. I think that's another thing that we're grappling with these days. So prognostic awareness and prognostic acceptance, 2 different things. So here's my prognostic discordance paper that I also found this year, published in JAMA Oncology. So 236 patients and I think it was about 60 oncologists. This was done in New York and Sacramento, California, this questionnaire. And the patients were asked what their 2-year survival rate was for lung cancer. There was other cancers too, but for lung cancer it was what is your 2-year survival rate? And they could either say 100%, 50 to 75, less than 50%, or 0% chance I have of living to 2 years for stage 4 lung cancer. So when they asked this question, 68% of the patients had a discordant view. It was not the same as what their prognosis, the oncologist said. Whether it was better or worse, it wasn't the same. Interestingly, to throw a cultural aspect into it, 95% of African American patients had a discordant view of what their oncologist told them. And interestingly, 89% of the patients that had discordant views didn't think it was different than what their oncologist thought, which made me kind of laugh because I thought, okay, I guess that means 11% knew they were wrong but didn't care and wanted to remain hopeful, which is always fine as well. Coming to terms, accepting prognosis is very complex. It depends on the patient's personality, their views on life. We can't change that, and it's not our job to change that. We have to bob and weave. We have to adjust to our patients and what's right for them. I'll just give patient experiences. Tracy and I had a patient many, many years ago, an elderly woman, and she had a very slow-growing cancer. I can't remember if she was EGFR positive or not, but when we told her she had stage 4 lung cancer, she said, well, I joined the Hemlock Society, remember her? And I was like, that doesn't sound good. I don't know what that is, but I should go look into that. And she informed us that she would not harm herself physically, but she was ready from day one. That's fine. I'm okay with this, and I'm going to die of this, and I'm going to move on. Versus the complete opposite of patients who say, listen, I want everything done possible. I don't want to hear you talk about like bad prognosis or anything negative. So we have to be able to adjust to our patients' needs while being realistic at the same time. Awareness and acceptance. If you have both prognostic awareness as well as accepting it, you have less anxiety and less depressive symptoms, though patients also perceive themselves as being a burden to others. So that is still kind of always in the mix that we have to, be thinking about. Now, if they had awareness, but they weren't accepting their diagnosis, that was associated with suffering, depression, and hopelessness. So unfortunately, we can make patients aware of their prognosis, but that doesn't mean they're always going to accept that. So that can be a problem. Prognosis understanding, more on this. So 686 patients with metastatic lung and colorectal cancer were surveyed 3 to 6 months after their diagnosis. 16% actually knew their accurate diagnosis, and that was determined as lung cancer being less than 2 years to live. So only 16% of them thought they had less than 2 years to live. Most thought they had more than that. The earlier prognosis was discussed, the more understanding was reported for the patient. So again, I'm not saying that you have to go in and say, oh, you have stage 4 lung cancer, you know, you're going to die, it's bad things. But also it's important that they know this is something not curable, but we are hopeful. We're going to do everything possible we can to do what's right for you. If you want treatment, we have these options. NCCN guidelines, palliative care guidelines, they're fairly recently updated, so I wanted to put these up. If you feel that your patient has months to a year to live, again, review the burden of cancer symptoms, okay to go on with anti-cancer therapy, symptom management, assess their understanding of prognosis and goals. I had a guy last week, I think he's in his mid-50s. He was not looking at me, he was on the exam table, so he's looking forward. And patients do this. They say, yeah, I really want to make it to my son's graduation in 6 years. Now, he wasn't looking at me, so he wasn't really asking me, but I think he was asking me. That's what I'm trying to say. Like, people will throw that out there while you're in the exam room with them, and that's their way of asking you. They're not asking you, but they are. So I remember I sat there and I'm like, what do I say? Do I just blow that off and let him think that? You know, he was on second-line therapy at this point for stage 4 lung cancer. My answer to him was, I remain hopeful, though that's not the averages. We're going to do our best to do what's right for you and help you achieve any kind of goals that we can. That would be, but there was a brief moment where I was like, I'll just blow that off and pretend like I didn't hear it. But then I thought, that's his way of asking me. So he doesn't have to come out and say, how long do I have to live? So realizing situations like that and then thinking about how you want to manage them. Obviously offering palliative care at that months to year mark. Months to weeks, it's time to redirect the goals and hopes. Confirm that they understand that this is an incurable disease and considering discontinuation of therapy. A little bit more on difficult discussions. The patient who does not want to know. I had the advantage of listening to Dr. Necka Cederstrom. She's the ASCO Ethics Chair Committee. She was great to listen to, and she was kind of role modeling of how to deal with when the patient's family comes in and says, don't tell mom that she has stage 4 lung cancer. Okay, well, you know, why don't you want her to know? And that would be one of the first things that we should ask. If a family member says, why don't you want them to know? Ask them, are you afraid of their reaction? And then they say, well, she'll become hopeless and she won't want to live any longer and she'll become very upset. At that point, Dr. Cederstrom's answer was, I have a patient-physician relationship that if she asks me questions about that, I have to be honest with her. And that's the most important thing. Because if I am not honest with her, then I completely have not done my job and I'm not being truthful with my own patient. So it's important to say that to family members and explore what their reasoning is for, you know, not wanting a family member to know this. There's a couple models I'm not going to go into too much, other than to say the comfort model is to have good body language, remain calm, allow patients to talk, and just listen to them, learn the family dynamics and the wishes. Again, this goes back to the patient-physician relationship. There has to be a relationship that's developed, which is another reason I don't necessarily think on the very first visit all of this has to be discussed. This is something that you have to get to know your patient a little bit better. Another model just for affirming the patient's beliefs that, yes, it's okay, I remain hopeful with you. No matter what, I'm committed to you and doing what's best for you, but also educating them and say, listen, I have some things I think we should talk about. Which factors are important to patients? So this was a study of 352 patients just with lung cancer. 54% received disease-directed stage-appropriate treatment. That means almost half of them didn't. The higher probability for them getting the appropriate treatment, the first three I found normal. The last one I thought was interesting. So risks of treatment were discussed, goals of treatments were discussed that helped them make a better informed decision and their chance for cure. They knew if it was not curable versus curable disease. And then if their physician was warm and friendly, that predicted for them to actually get the appropriate therapy. So for whatever reason, that just reminds us, you know, what we're doing there, seeing cancer patients. End-of-life discussions, Dr. Kumar is going to go into this too. This is a paper that just has to be mentioned. So again, end-of-life discussions on average 33 days before death, so it should be longer than that. end-of-life discussions, this has been shown over and over again in the literature, do not cause depression, they do not reduce survival, and they do not take away patients' hope. So that's been shown over and over. The major barrier of poor prognostic communications is not the patient, it's the stress and pain suffered by the physician. So I know that we find our jobs to be stressful and painful. Everybody can say what their different positions are and what is stressful and painful for them, but I would completely agree with this. I enjoy looking at CAT scans of the chest all day. I know it's weird, but I think there's a lot of people in here that like it too. And I enjoy talking to patients about toxicities of treatment and consenting. But that is hard. That's the hard thing, that you take a deep breath before you go in the room. So we have to at least be, comfortable with ourselves so that we can do this for our patients. There is an ASCO position statement on end-of-life care. I'm not going to read through it. I just included it in the slides, so I'm running out of time. Another study, the one on the bottom, the 145 patients, 79% had a decisional capacity at the time they entered the hospital, but 40% of them lost that capacity by the time a decision needed to be made. And when a surrogate makes the decision, patients are more likely to have aggressive care at the end of life. So really try to know what your patient's hopes are. This was a study looking at patients and where they received their aggressive therapy, 9% in the ICU in the last 30 days of life. If you had an end-of-life discussion prior to the last 30 days of life, they were less likely to have aggressive treatment at the end of life. Again, just confirming that it's better if they know their prognosis before the last month of their life. I'm going to skip through that one. I want to get to the special populations. So end-of-life discussions and cultural differences. So there's a couple papers out on this. Black patients are more likely than white patients to receive life-prolonging care at the end of life, specifically CPR, though it was equal when they were still on chemotherapy. In this couple papers here, white patients were more likely to receive the end-of-life care that they preferred, whether it was aggressive or not. And patients who report high religious coping are more likely to want aggressive care at the end of life. This has been shown in a few studies as well, which surprises me, but this has been shown over and over again as well, that they are more likely to opt for aggressive end-of-life care. I'm not going to go through all these as well, but again, there's different provider views on a good death versus African-American traditional views on a good death. And I don't know if this paper had any religious backing to it or not, because a lot of these are kind of religious statements. But this was actually written by, or the study was done by an OB-GYN who has a specific interest in end-of-life care, oddly. Teaching caregivers about end of life. So if patients' family members ask you, again, most of the time it's just allowing the person to talk and express their fears and just being there to listen. Reminiscing is fine, but respect their need for privacy and support them in whatever kind of spirituality. Pray with them if they want is fine. Talking to children, there's one word, and that's to be honest. So this is over and over again. Make sure that you're honest with children. Obviously, you don't have to give numbers and be scary about it, but you also shouldn't lie to them, because apparently then when it does happen, it can be much worse for children. My last thing to finish up is documentation. On your electronic health record, do you know where your advance directive is and whether or not it's been discussed? Luckily on ours now, we do have in yellow highlighted at the top. Problem is it's not always filled in. But this is a good thing to have in your electronic health record, because you know when a patient is going down the tubes quickly. It's nice to be able to look really quickly and find where their advance directive is and what it says. So that should be well documented, hopefully. So my conclusions are that there's several barriers that exist to end-of-life discussion. Not only the physician and patient, but now we're kind of grappling with the media and marketing. Facilitate discussions about prognosis or end of life by using certain phrases or validating concerns. End-of-life discussions do not increase symptoms. It's been shown over and over again. And facilitate a relationship with your patient and their family. That's the best way to learn and understand what their needs are. Thank you very much.